Good evening, everyone. Thank you for coming. I'm Dr. McNicol. I've been here at KCH for approximately, a little over 2 years now. I'm from Ohio, from northeastern Ohio, just south of Youngstown. Pretty much lived in Ohio all of my life, except for where I did training at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. Lived there for about 5 years, did my anesthesia residency, and then did my fellowship training there as well for pain management. So we can get right into it. So today what I would like to discuss is some of the modalities that we use for managing chronic persistent pain. So we'll go through some of the things. This is not an exhaustive presentation by any means. There will be some time toward the end where we'll open it up for questions, and you guys feel free to ask, okay? This is just a part of our team here. We've got an absolutely fantastic staff. Everybody's incredibly nice, very understanding about the field in which we are operating. So if you guys do come see us, these are some of the faces that you'll see. This is actually at our Centerburg location, so if any of you have been or had the chance to frequent there. We service both here in Mount Vernon, and we go to Centerburg at least twice a month. So if you live closer to there, if it'd be more convenient for you, know that that is an option for you. So what do we do? So acute pain, chronic pain is a very, very common thing that happens to a lot of adults in the United States. The majority of what I see is lower back pain. About 50% of adults in a given year will have some degree of back pain at some point. Whether that becomes chronic, though, depends on quite a lot of factors. So typically what we consider chronic pain is any pain that's lasting 90 days or 3 months or longer, okay? So with respect to our clinic, I'm employed by a private group, which is a joint venture with the hospital system. So we come together to provide the services to the hospital. So again, I'm fellowship trained. Typically how we get patients to see us is by a primary care physician. They're usually the initial point of contact for most people. And then they can help get everything set up for you. We do not 100% require a referral. Self-referrals are accepted, but we do prefer that you have a primary care doctor, so if there are any other issues that need to be addressed, we can refer you back to them. Quick question too, how many of you know where our clinic is physically located? Okay, because that's a very common question that I get. There's a lot of confusion. So if you're pulling into the hospital on the opposite side, we're the only one-story building on campus. So hopefully that makes it a little bit easier for you. So the current state of managing pain, there's quite a lot of overlap in various specialties within medicine. So it can be a little overwhelming, particularly being a patient, of where do I go, what do I do, who do I talk to help manage my pain. So we do get referrals from all sorts of specialties. Around here, typically primary care. We did have a neurologist. We will be getting another neurologist. Which is going to be important. We do get referrals from the orthopedic surgeons here, from the general surgeons here. We will occasionally get a referral from the emergency department. If any of you are undergoing physical therapy, maybe a physical therapist would think that you could benefit from our services. So we do see from all walks of life here. So what we like to provide is a balanced treatment plan for our patients. So when managing chronic persistent pain, most often it's not going to be just one thing that helps the pain. So we use a multimodal approach, and I'm going to go over what that means. But this slide here is just to demonstrate that we incorporate a variety of things to help treat the pain. So I'll go over some of the interventional procedures. We'll talk about some medication management, some of the adjunctive therapies or other alternative therapies that we can use to employ to treat the pain, as well as potentially needing a surgical evaluation. So some of the medical therapies that you may have employed in your own pain management, the typical things you start with, especially when it's acute pain. So resting the injured portion of your body, using some ice, using some heat, physical therapy and stretching. Those are the important things to help long-term pain management. Anti-inflammatory medications, those would be things such as ibuprofen, Aleve, and there are some stronger alternatives that are prescription only. Quite commonly we use oral steroids. You may even have some steroid injections into various joints, knees, shoulders. And we also use a lot of nerve pain medication. So the common things you may have heard of are things like gabapentin, Lyrica, pregabalin, Neurontin. We quite commonly employ muscle relaxers because anytime there is pain, there is likely an associated muscle attached to where that source of pain is occurring. And if you can get that muscle to relax, often you can help relieve some of that pain. TENS units, I tend to use them on some patients. It's a very, very non-invasive way to help treat pain. So those are certainly an option as well. They can range in price. They all basically do the same thing. So don't think that a $200 device is going to be any better than a $25 device, okay? Some of the common interventional services that we offer are trigger point injections. We use these for muscles that are irritated. When muscles get irritated, sometimes they stay irritated, and they stay that way until you intervene on them. So it's a very non-invasive way to treat some muscle pain. Joint injections are quite common. You can imagine that as you're walking around throughout your life, your knees are going to get worn out, your shoulders might get worn out. So a simple intra-articular injection to either of those spaces as well as others can be beneficial. Commonly, I see people with pain that travels down into their legs. A lot of the time it's a disc that's bulging or herniated. Sometimes it's the arthritis that's causing a problem. And if we can calm down that inflammation and irritation at the source in the spine, then we can get things resolved. A lot of the time people deal with arthritis in their back. And so the joints in the spine are called facet joints. And those are a very, very common source for pain. That is going to be pain that really limits the amount of time you're able to stand on your feet or walk. You've got to sit down, you've got to lie down to help relieve some of that pain. So that's a very common thing that we do. To help more semi-permanently treat this pain, we couple these two and do something called a radiofrequency ablation. You may also know it as a neurotomy. All means the same thing. What we're essentially doing is, again, targeting those facet joints in the spine that are very arthritic, and we're essentially heating them up to disrupt those nerves that send pain signals to the brain. Again, semi-permanent basis, but we've had a lot of success with it. So say that you may have already had some of these therapies done, and you're still finding yourself in pretty debilitating pain. There are some more advanced interventional spine therapies that we can do for you. Spinal cord stimulation is a relatively non-invasive way to help treat pain that involves implanting a little tiny metal electrode into the spine that stimulates the way that the pain signals get sent in the spinal cord. So it alters how your brain is perceiving the pain. That can be done for people who have already had back surgery or are not a candidate for back surgery. Again, a less invasive way to help treat the back pain. I talk a lot about back pain because that's the majority of what we see, but if you've got any other types of pain, we'd be happy to take a look. Some of the other common things that we can offer are kyphoplasty or vertebroplasty. Quite commonly, especially in older women, your bone density tends to be lower and you put yourself at increased risk for developing a compression fracture, okay? That's when the bones, the vertebrae, get compressed. There can be quite a lot of pain associated with that. And if you'd be a candidate, what they can do is inject some cement or a cement-like material to help give that vertebral body more strength and help reduce the pain. One of the things that I actually introduced to the Knox Community Hospital system here is peripheral nerve stimulation. So we do peripheral nerve stimulation for a variety of maladies. We've had patients come through that have had carpal tunnel syndrome, and they've gone through the surgery, and yet they're still left with debilitating pain. We can stimulate that. It's a very simple thing to do. It's very similar to spinal cord stimulation, but instead of going into the spinal column, we're going more peripherally where the nerves themselves sit. So I do peripheral nerve stimulation. If you can find the nerve, you can stimulate it. So it's an ultrasound-guided procedure, very, very simple thing to do. Sometimes these interventions that I can offer you aren't enough, and it would require a surgical referral. Maybe there is a physical issue that needs to be fixed. Maybe there's a disc that's herniated, or the degeneration in your spine is just so severe that it does require surgical evaluation. So surgeons then would be able to do a discectomy where they basically scoop out the disc, and some more advanced things like spinal decompression therapy where they remove some of the bone to allow more space for those nerves and the nerve tissue to breathe. And spinal fusion is required in some cases, depending on how extensive the degenerative changes are. So just to give you a little visual here, again, a very common thing that I employ to help people with pain, especially pain that travels down into the legs. It's a very minimally invasive procedure. We do this at our own clinic here. It takes me less than 5 minutes to do, potential to offer you significant benefit, okay? I do most, if not all, of my procedures with ultrasound or X-ray. This one requires an X-ray camera to do. That's very precise. So we get the needle in place, we put the medicine in, okay? Here is one of the other procedures I was alluding to. This is targeting those facet joints that can be very, very arthritic, very, very uncomfortable. Again, those are the ones that are causing you a lot of issues with standing or walking. So picture's a little small, but essentially what I'm showing you are the targets for these. So it's done on a semi-permanent basis. The reason it is not permanent is because the nerves grow back, and they grow back in varying rates in every individual. So we expect it to last about 6 to 12 months, and if it's helpful, we can always do the ablation again. So some of the most common diagnoses I see are neck pain. We do treat work-related injuries. We see a lot of back pain. Again, I went over some of the statistics with that. Persistent pain in the back or the neck, arthritis pain in the lower back or neck, complex regional pain syndrome. That's a little bit of a rarer entity, but we do treat it. We have quite a few modalities to treat it if you or someone you know has this. Usually caused by an injury or surgery to an affected limb with pain continued longer than 3 months after the surgery has taken place. We deal with a lot of nerve damage and muscle spasm pain. Again, I mentioned the trigger point injections for you. And we deal with shingle pain. So if you've had shingles or know somebody who's had that, you know how debilitating that pain can be and how persistent it can be despite the resolution of the rash. We also were the first to introduce a new type of therapy for shingles and diabetic-related neuropathy. As a matter of fact, it's called Qutenza, and it is a simple patch that we put on in our clinic. We've had some degree of success with it as well. So why does all of this matter? So one of the things that people like or don't like to talk about are opioid medications. So we know what they've done in this country. We've seen some of the negative aspects of how they've kind of ravaged some people's lives. I myself know of quite a few high school classmates that have overdosed and died because of opioids. So it's affected me, and I'm sure that it's affected somebody you know. So the short-term use of opioid medications is appropriate. So something you have an injury, you break an arm, you have a surgery. Prolonged use of narcotics is no more effective than Tylenol or any anti-inflammatory, and that has been borne out by study after study after study. Long-term use of opioids can lead to tolerance. So tolerance is when your body has seen a medication day in and day out, and it gets very used to it. And then suddenly you're finding that it's not helping your pain as much as it used to be. Addiction is also a very concerning thing, and that can be difficult to differentiate sometimes between tolerance and addiction. Long-term use can actually make pain worse and is linked with an increased risk of death. So there's a term I put up here called opioid-induced hyperalgesia. So that's a lot of fancy words to say that if you've been on a medication like an opioid for a prolonged period of time, what happens is your body increases the number of pain receptors because it doesn't know what else to do. So with that increased number of pain receptors, now you're going to be feeling even more pain than what you were previously having pain due to. So someone like myself, I'm not taking these medications on a regular basis. I go and I stub my toe. Might hurt about a 3 to 4 out of 10. Someone who's taking these medications long term, well, they've got all those pain receptors increased. They're going to be at about a 6 or a 7. So it's a real thing. It's study backed, but it's a big concern. So just to give you some more statistics, over 290 Americans die every day from unintentional drug overdoses. These people are not doing it on purpose, but they don't know what they're getting their hands on. So these are just some statistics from the state of Ohio. For between 20 and 2021, we saw an increase overdose death in Ohio from oral medications, fentanyl, and heroin. This is a little statistic map showing where Knox County is itself and our relationship to other counties in the state of Ohio. So since 2007, the overdose deaths in this county increased, but we did not increase as fast as other counties did. So there's a variety of reasons for that, but I think kind of reining in a little bit of the use in prescriptions is a big factor in that. So, benefits to this county in the year. So 3 out of 4 patients in Knox County would recommend the Knox Community Hospital Pain Management Center. The 85% statistic that you're seeing here is real-world data. This is data coming from our clinic. So we keep track of all of this through our proprietary data management system. We have 85% of people reporting moderate to significant relief. I know that some of you may have already been through some pain management things, but I'm always coming at something with a fresh eye. So if there's something that I see you haven't had done or haven't tried in the past, anything is worth a try when you're dealing with persistent, chronic, daily pain. Thank you all for coming. Have a good night.